Yeah, I'm Dr. Ibrahim Aldoss from the Division of Leukemia, Department of Hematology and Stem Cell Transplant at City of Hope in Duarte, California. The question today, what is the difference between chemotherapy and immunotherapy, and which one is best for me? So both immunotherapy and chemotherapy play vital roles in the treatment of acute lymphoblastic leukemia. Rather than viewing them as competing modalities, it's important to recognize that they're complementary in nature. In regard to chemotherapy, frontline treatment of acute lymphoblastic leukemia routinely involves multiple chemotherapy agents used in various combinations. Chemotherapy has been the foundation of ALL treatment for several decades, and its strategic use has significantly advanced cure rates, especially among children and young adults with acute lymphoblastic leukemia. Now, the way that chemotherapy works is by targeting rapidly dividing cells, but its effects are generally non-specific as compared to immunotherapy. As a result, healthy cells that also divide quickly, such as blood cells, can be affected. This often leads to low blood counts, which increase the risk of infection, bleeding, leading to fatigue, and generalized weakness as well. In addition to blood side effects, chemotherapy commonly causes nausea, vomiting, hair loss, decreased appetite. Chemotherapy can be administered intravenously, either as an infusion or as an injection. However, some chemotherapy agents used in ALL treatment are also available in oral formulation taken as pills. Now, despite advances in immunotherapy, chemotherapy remains a vital component of ALL treatment for children and young adults, particularly those patients with T-cell acute lymphoblastic leukemia and those what we call Philadelphia chromosome negative B-cell ALL, where using tyrosine kinase inhibitors, a form of ALL therapy, is not available for these patients. Now, in regards of immune therapy, several immune therapies have been approved for the treatment of ALL, all of which currently target CD19, a protein that is commonly expressed on B-cell ALL cells. These therapies harness the body's own immune cells and system to eliminate cancer cells. While immune cells are naturally equipped to fight cancer, malignant cells can avoid immune detection. So immune therapy, what it does, it helps restore and enhance the immune system ability to recognize and destroy these cells. There are two main classes of immune therapy. The first one called bispecific T-cell engagers, or they refer to them as BiTEs. And these are engineered molecules with two binding sites. One binds to the CD19 on leukemia cells, and the other one binds on another protein called CD3. And this protein is present on T cells, a key immune cells we have. Now, by bringing T cell into proximity to leukemia cells, PI trigger targeted cell killing. The currently approved bispecific antibody for B-cell ALL is called blinatumomab, and this is currently the only approved one, but there are other actually drugs are being tested with the same mechanism of action. Now, because blinatumomab has a short half-life, it is given as a continuous infusion for 28 days every 6 weeks. Then patient, after the 28 days, they have 2 weeks break before they start the next cycle. Now, blinatumomab is currently approved for newly diagnosed Philadelphia chromosome negative B-cell ALL in patients who achieve complete remission, where they clear the disease by initial chemotherapy. So we call it as a consolidation treatment. It's also approved for patients who achieve remission, but they still have detected low level of disease. We refer to it as minimal residual disease, or MRD. But it's also approved for patients either they fail to respond to chemotherapy or they relapse after prior response to chemotherapy. Now, the other type of immune therapy that is approved in acute lymphoblastic leukemia is called CAR, or chimeric antigen receptor T cell therapy. This therapy involves collecting patient own immune cells, T cells. Usually we collect them from the patient bloodstream. Then after we collect them, we genetically modify them to express synthetic receptor that target the same target of blinatumomab, the CD19, that is almost universally present on B-cell ALL cells. Now, after a short course of chemotherapy, these modified T cells are infused back to the patient. The engineered T cells will circulate throughout the body of the patient and directly looking for ALL cells and directly kill cancer cells. So the CAR T cell therapy is highly effective, even in patients who failed prior blinatumomab or have disease outside the bone marrow. We refer to it as extramedullary disease relapse. Now, there are several CAR T cell products are approved for B-cell ALL, all the approval for patients who failed prior therapy. And they're kind of different in the construct and some of the characteristics, which may reflect in difference in the toxicity and how long they stay in the body. We refer to it as persistence. So unlike blinatumomab, CAR T cells require a manufacturing process, and it's not immediately available like blinatumomab, where you can just give it to the patient. It's a process to manufacture these cells and takes roughly 4 weeks by the time we collect the T cells and by the time the CAR T cells are ready to infuse. Now, immune therapy, they have a unique toxicity, unlike chemotherapy, so you don't see frequently patients develop nausea, vomiting, low blood counts. However, they have distinct side effects. One of the important side effects is referred to cytokine release syndrome. It's an inflammatory process, usually present as a fever from activating patient own immune system. And in severe cases, this can lead to low blood pressure and reduced oxygen level and potentially requiring ICU care. Now, our ability to manage cytokine release syndrome early has improved over the years with the experience of actually administering immune therapy, and we're able to interfere early to prevent a severe form of CRS or cytokine release syndrome. The other toxicity for immune therapy is what we refer to as neurotoxicity, which is brain-related symptoms can range from headaches, shaking in the hands, referred to it as tremor, sometimes can be confusion or change in mental status, and in rare cases can be seizures, but can also be unresponsiveness as well. Although this can happen more often with CAR T cell therapy compared to blinatumomab, it can be manageable with the administration of steroid to kind of suppress the immune cells from causing this toxicity. While these side effects tend to be more severe and prolonged with CAR T cell therapy compared to blinatumomab, they can vary across the different CAR T cell products. So nowadays, immune therapies are only approved and commercially available for B-cell phenotype of ALL, but not for the T-cell acute lymphoblastic leukemia. There are some studies evaluating a new immune therapy for T-cell ALL, and early data is encouraging, but unfortunately, until now, nothing is approved. And finally, I mean, there are other modalities of targeting ALL, in a class of drug called antibody-drug conjugate. We have a drug called inotuzumab that is approved for relapse or refractory B-cell ALL. It targets another protein that frequently expressed on ALL called CD22. The antibody is linked to a potent cytotoxic agent called calciumycin, which is delivered directly into the malignant cells once the drug binds to the CD22 on the surface of acute lymphoblastic leukemia. And once it binds, it enters the ALL cells, then the toxin-induced DNA damage leading to cell death. This targeted approach allows for enhanced efficacy while potentially reducing systemic toxicity compared to traditional chemotherapy. Now, some questions you need to ask your doctors about the topic is there a rule for immune therapy in your ALL treatment? Which immune therapy is more appropriate for your disease if relapses? And if it is appropriate to give it with first-line therapy for newly diagnosed leukemia? And how is a particular immune therapy is given? And what are potential toxicities for immune therapy?